Good morning, good evening, good afternoon. You are welcome again to this new IHCH Junior Clubs. Today, we have the pleasure to have Dr. Nicoletti, that is a resident in clinical hematology, that is going to discuss the case of a 20-year-old acute lymphoblastic leukemia that developed a stroke-like syndromes after methotrexate. This is a very uncommon condition, so we are very happy to have the possibility to hear about that and to discuss. We are also very pleased to welcome Professor Mark, that is working at the University Hospital Bristol NHS Foundation Trust in the UK. During the presentation, do not hesitate to send your question in the chat. We'll try to address all of them with both Dr. Nicoletti and Professor Marks at the end of the presentation. So please, Dr. Nicoletti, the floor is yours.
Thank you very much. So I'm going to start this presentation with a brief resume of the case story of this patient. She is a 20-year-old woman with no real familial history, no important medical history apart an endometriosis and a 2 months hormone replacement therapy for a notion of hypothyroidism. And she presented in July 2023 to the emergency room with complaints of B symptoms, meaning fever and weight losses. They were evolving for the last 2 to 3 months. And she also was suffering from an epigastric abdominal pain. The first laboratory findings, which were performed on peripheral blood, found an anemia at 9.4. Platelets were low, as well as leukocytes and neutrophil count. So at the resume, she was presenting with a pancytopenia with no circulating blast. She had a moderate inflammatory syndrome with a C-reactive protein around 20, and the remaining tests were normal. So with this pancytopenia, she was referred to the outpatient hematology consultation. The first assessment was a sternal bone marrow aspiration, which found a medium age-adjusted cellularity. And she also had 45% of lymphoblastoid cells. The cytogenetic abnormalities were the following. She had a high hyperdiploid karyotype, and no ETV6, BCR-ABL1, TCF3, or MLL fusion genes by FISH. The molecular genetics didn't find any CRLF2 or EPO receptor overexpression, no Icaros or HERG deletion. And the flow cytometry analysis on the bone marrow cells found a phenotype compatible with the AGIL2 BLL2 phenotype. She had no tumoral cells in the lumbar puncture, no neurological symptoms, and it was finally concluded that she was presenting with a high hyperdiploid, non-hyperleukocytic CNS1 B2 acute lymphoblastic leukemia. The serological testing were simply with a EBV positive and toxoplasma positive serology compatible with an old infection, and there were no otherwise remarkable data. The treatment was according to the FRAIL 2000 protocol, the French protocol, which is as follows. First, there is the prephase that she went through in July with corticoids, but also administration of intrathecal chemotherapy, intrathecal methotrexate. Then she went through the induction phase with administration, again, of corticoids, vincristine, daunorubicin, L-asparaginase, but also a triple intrathecal administration of chemotherapy. The first bone marrow evaluation at day 21, an early evaluation found no lymphoblastoid cells, and the post-induction evaluation found a complete molecular remission with an indictable MRD at a 10-4 threshold. She finally went through the consolidation phase with administration of etoposide, aracitin, again, triple intrathecal administration of chemotherapy, as well as high-dose methotrexate. She received 5 grams per square meter per day of methotrexate during 2 days at day 21, day 43, and also, again, triple intrathecal administration of chemotherapy. Finally, the evolution was a neurological deterioration on October at day 47 of the consolidation phase, and 4 days after the last administration of chemotherapy, she presented sudden onset of neurological symptoms. These are tria, right hemiparesis, and all these symptoms were suggestive of a stroke. At the physical examination, she mainly had focal neurological signs, including dysarthria paresis, right central facial palsy, right hemiparesis, with a decrease in the muscle strain testing at 3 out of 5 on the right upper limb and the right lower limb. She didn't have any sensory loss. And the finding on the peripheral blood found an anemia, calcemia, normal sodium, and she also had normal liver test, normal coagulation test. It was decided to perform an urgent brain MRI to this patient, which is as followed. She was presenting a 23 per 15 millimeter signal abnormality in the left frontoparietal region. Involving the white matter. This lesion was in diffusion hyperintense and ADC hypointense, so a restricted diffusion. She had no signal change on flare. She has no gadolinium enhancement, and there was no argument for a vascular anomaly since the TOF angiography was normal. So we ended up with a encephalopathy symptoms with this patient, and we went through the possible etiology of this disease. Most of them were quite easy to exclude. She had no argument for infectious. She had no fever. There was no reason for a dysimmune, a traumatic, a congenital, obviously, disease. She had no argument for a malignant localization of the disease inside the brain. And the final conclusion that the most probable possibility was a toxic reason for this encephalopathy. We ended up concluding that she was presenting with a methotrexate-induced stroke-like encephalopathy, a specific entity that I will go through later. The evolution of the patient was a rapid improvement within the first day, but also the evolution was waxing and waning because she had subsequent reappearance of dysarthria, and it was decided to give to the patient dexamethasone, so corticoids, which allowed the improvement within a few hours. This specific entity, methotrexate-related stroke-like syndrome, is well described in the literature. But when we were looking at the prevalence of this disease, we need to have a good definition. There is a good publication in the Lancet Oncology in 2016 who defined the methotrexate-related stroke-like syndrome as follows. It's a neurotoxicity, which is typically occurring within the 21 days of IV or IT methotrexate administration, and it needs to have 3 different characteristics. First, it's new symptoms. So new symptoms, whatever neurological symptoms the patient is presenting, from paralysis up to seizures, any neurological symptom. It needs also to have some specific characteristic at the MRI. So the most common characteristic, but which is very often transient, is white matter changes, compatible with the leukoencephalopathy. Or the patient had to present characteristic clinical course with the waxing and waning evolution. So symptoms are coming and they're resolving spontaneously. And finally, it's necessary to exclude the other possibilities of encephalopathy. When we look at the literature through the years, so there are many studies. I selected some of them here from 2007 up to 2023. The 4 first studies are pediatric studies because most of the studies are pediatric studies. And what is found is that among the patients from the French protocol, the FRAL, the old protocol, the FRAL 93 protocol, but also in the States with the St. Jude Children's Hospital in the GCO in 2014 and in another publication in 2018, it's between 3 to up to, at the maximum, 40% of the patients who are presenting this toxicity. There is very few studies among adults, but there is a presentation at the last EHA Congress, which was performed at the Mount Sinai Hospital in the America. And they found more or less the same, with 7.6% of the adult patients presenting methotrexate neurotoxicity. So finally, it's commonly reported an incidence between 3 to 7% among most of the paper. These papers over, let's say, 20 years of studies with the modification of the protocol with more chemo-intensive protocols have no modification in terms of incidence of the disease. And both IT and IV methotrexate related cases have been reported in the literature. The first question is, can we predict this neurotoxicity? There have been a lot of studies on the subject, and most of them can find the following clinical risk factors. First, it's more often associated with the concomitant administration of IV cyclophosphamide and aracetin. Also, it's associated with the cumulative exposure of the chemotherapy. So more often we can observe these symptoms in the intensification phase. Among the pediatric patients, we can find them with the patient who are older, and the threshold of 10 years old have been proposed. It's also observed more often in the Hispanic ethnicity patient. There is no impact of the acute lymphoblastic leukemia subtype, no impact of the sex of the patient, or other clinical parameters in the literature. Finally, it has been also studied some possible link with the genes involved in the methotrexate metabolism. I will go through it in the next slide. The message is that some genes, some polymorphisms in MTHFR, ABCB1 have been described with an increased risk of high-dose methotrexate toxicity, but these genes per se are not sufficient to be integrated in the clinical decision, and they need to be integrated in models which are still lacking currently. When we look at the way the methotrexate is active, it's inhibiting DNA synthesis, and it's inhibiting two important enzymes, the dihydrofolate reductase enzyme, but also the thymidylate synthetase. Both methotrexate and its metabolites are active on these enzymes. And the studies that I figure out here in pink studied these genes, and all these genes, depending on the studies, can be associated with an increased risk of neurotoxicity in the literature. The following question is, can we prevent this neurotoxic event? To answer this question, it's important to understand the way the mechanism is involved, so the pathogenic mechanism. There have been three main hypotheses in the literature. The first one is an imbalance in folate homeostasis due to the mechanism of action of methotrexate, and as a consequence of it, an impaired myelin turnover. Another hypothesis is involvement of a vascular disease because of a homocysteine release, and as a consequence, an endothelial cell damage. And finally, it has been proposed an indirect neurological cellular damage because of the release of adenosine from endothelial cells and fibroblasts. And this adenosine is then responsible for a neurotransmission alteration, and both at the pre- and postsynaptic stage. Because of this hypothesis, it has been proposed some possible therapeutic option. Since these hypotheses are based on homocysteine and adenosine, some teams propose the use of aminophylline, of dextromethorphan, that I will go through it a bit later, which can counteract the possible action of methotrexate. Clinically, how do we manage this patient? It's mainly supportive care and monitoring of the patient because of the spontaneous evolution of the disease. If symptoms are severe, you need to admit the patient in intensive care units. The evolution is waxing and waning, as said earlier. There is no systematic need for a CT scan. If accessible, the MRI is important because it can help for the diagnosis. And there is no systematic CSF examination unless the patient is presenting with fever and that you need to explore to exclude the possible infectious disease. For the specific therapeutic interventions that have been proposed, dextromethorphan is proposed to act through some N-methyl D-aspartate receptors that could counteract the action of homocysteine elevation. And aminophylline is proposed to act on the adenosine pathway by displacing the molecule from its receptor on endothelial cells. But the message is that we can't give some specific recommendation because of the lack of control trials with these interventions. Then the question is, should we re-challenge the patient with the methotrexate after such a soft neurotoxic episode? The answer is, as much as possible, yes, because if you omit the methotrexate administration, then it's associated with an increase in CNS relapse. This is an Australian study who shown in green. You can see if the intratexal methotrexate is continued compared to the blue patient in which it has been ceased, and there is an increase in the cumulative incidence of CNS relapse. On the other side, if the neurotoxic toxicity is occurring early in the course of the patient, it's associated with a leukemia-free survival decrease because most often some teams are stopping or delaying the administration of chemotherapy, and as a consequence, there is an increase in relapse. So the challenge has to be done, and most of the time it's a safety re-challenge with more than 80% of the patients who do not develop recurrent symptoms. So this is written here. We can also discuss when you re-challenge methotrexate, the administration of leucovorin rescue, which is supposed to decrease the possible neurotoxicity of methotrexate. Then can we have patients with recurrence? The answer is yes. It's between 10 to 15% between the studies in the literature. But even if this patient, methotrexate can still be administered over the course, but there is a lack of studies regarding the long-term neurological outcome of this patient, especially among the pediatric patient. There have been some papers describing epilepsies among patients with neurotoxic events. And also there is a paper who described that acute leukoencephalopathy for childhood ALL was associated with a prediction of a higher risk for long-term neurobehavioral problems among these patients. There is no guidelines for a second re-challenge. And I will conclude with these following take-home messages. First, it's a rare but well-defined entity in the literature. There is very few studies among adults. Most of the studies have been done among children. The main clinical risk factors have been well described. There is also some pathogenic mechanisms that are proposed, but they are still elusive. There is no strong demonstration. And because of this, there is no specific therapeutic intervention that can be recommended apart supportive care. As much as possible, methotrexate re-challenge has to be done among the patient to avoid the CNS relapse and the decreased survival, which is well documented among the patient in which it stopped. And also consider as benign, there is a lack of studies among the future of this patient from a neurocognitive perspective. Finally, as a developing strategies among these patients, there is three main possibilities of work. There is people working on the possibility to decrease the frequency and morbidity of acute neurotoxicity. There is also work on reducing consequences on long-term outcomes of this patient. And there is a need for multivariable models to predict patient-specific toxicities. There is an interesting paper which has been published in GCI regarding efficacy and to predict the concentration of methotrexate metabolites inside the tumoral cells. But these models are probably interesting in the future because they can integrate both clinical aspects, but also pharmacogenetic aspects and the dose administration and all this data to have a specific prediction for this patient. With this slide, this is the last slide, so I will end here, and I'm happy to take the question.
So thank you very much, Dr. Nicoletti, for this very interesting case presentation and this very good literature review. It was very interesting to go into details as these, as you say, very rare conditions. So again, to the audience, do not hesitate to send your question to the chat. So I will direct my first question to Professor Marks. What is your feeling regarding this clinical case on this condition? This is something you see frequently in your patient that receive high dose methotrexate, or do you think this is something that maybe we misdiagnosed?
This is the methotrexate encephalopathy is not very uncommon. I think it's in the, as Simon said, in the sort of 1 to 5% range, but for it to manifest as what looks like a stroke, very uncommon. I think in my whole career, I think I've only seen a case like this twice, so really quite uncommon. Before I talk about it, may I ask you, Simon, how is the patient doing now, and what have you done with the further therapy of this patient?
Yeah,
in terms of exposure to methotrexate.
Yeah, absolutely. So the patient now is doing absolutely well. She recovered within the first week after the admission in the hematology department. And it was decided to continue according to the trial protocol. And she received again high-dose methotrexate administration. She didn't have any recurrence of neurological symptoms in the following administration, both IT and IV. And she's following the normal course without any recidue.
So I suppose the first thing is I don't think there's any doubt about the diagnosis here. I think it's quite characteristic. The timing is right. There doesn't seem to be an alternative explanation. I think this would have been an extremely frightening clinical episode for the patient. And I imagine when you talk to the patient about re-challenging them, that would have been, that would have been a tough conversation, because I think we are lacking literature about re-challenging. There are very good reasons to want to re-challenge, but the data you presented suggests that in maybe 10 to maybe more, 20% of cases, that there can be further problems with re-challenging. It looks like you're not going to have any problems with that. You've given both high dose methotrexate and intrathecal methotrexate. I mean, what I'm also interested in is your acute management. You ended up giving steroids.
Yeah.
Can you, just for the audience's benefit, can you tell us how much steroids you gave and for how long? And where did you come up with that dose, and what was the reasoning behind it?
Yeah. So honestly, the decision to give dexamethasone was completely empirical. This is a situation. This patient was taken care. We took care of this patient at the Saint-Louis Hospital in Paris, and it was not the first time that we saw these neurotoxic events. There is no specific guidelines inside our institution, but it was a personal experience of the PI who decided to give it dexamethasone, and we give only 4 milligrams of dexamethasone, and we decided to continue it up to 3 days depending on the symptoms. We were following the symptoms, and when she decreased when she didn't have any neurological persistent symptom, we decided to stop. But there is no strong literature to recommend such an attitude. It's really dependent on the teams.
So, however, there was quite dramatic improvement after the steroid. Of course, I suppose that might have occurred anyway. It's possible.
Exactly.
Did you consider using aminophylline? There's only a small literature about aminophylline. Was that considered?
We didn't consider it, but again, I can't say any justification apart from the habit, like what we used to do here in the team, but we didn't consider neither aminophylline nor dextromethorphan.
Yeah.
But I have to precise, just sorry, David, I have to say that we actually perform a dosage of homocysteine in the blood and in the CSF because we went through the lumbar puncture and there was no increase of homocysteine at the acute phase.
Right. And I'm not totally familiar with the FRAL 2000 protocol. Have you finished all the high dose methotrexate now?
At this time, yes. Now she is in the phase of after this phase, and she didn't have any new symptoms. So yeah, we finished.
And you're continuing with triple intrathecal therapy.
For the last time I saw the patient, I think she had at the beginning of the year, but I saw her like maybe 3 months ago. So I'm not sure where we are now. But we also continued the intrathecal therapy after the neurological phase.
Yes, so there's I mean, Florent, do sort of interrupt as you see fit. It would, if one, if there were further problems with methotrexate, it is possible to move to Aracy and steroid alone, but that is probably less effective than methotrexate. There aren't direct trials, but the sort of there's circumstantial evidence that that's less effective intrathecal therapy. Do we have any questions from the audience about how this was managed?
So we have two questions. One of them that asks if there is in the literature some mention regarding the glucarpidase. I don't know if you read about that, Dr. Nicoletti. No,
it's possible, but I didn't read any paper about that.
No, it was a question from Dr. Rosa. And we have another question from Dr. Roy that say that the fact that in the encephalopathy, you find that surprising to have this unilateral clinical and imaging finding, and that will expect to have something more bilateral. So if you can comment on that.
There are some papers regarding the typical aspect at the imagery at the MRI, and it's very often unilateral. It's very often this lesion with the oval shape of the lesion. We don't know why. We don't know the real mechanism under like the pathological mechanism. And I also have to say that it's easier to think about the methotrexate neurotoxicity in young patients. But when you have a like 40 or 50 years old patient who had some vascular, who's smoking or this stuff, the situation is more complex. And the radiological analysis made by the physician here, he was not sure about the presentation. He couldn't say for sure it's methotrexate. So it's more because of the patient. She was young. She didn't have any reason to make any other neurological toxicity. So that it was easy to conclude for the methotrexate link here.
Yeah, this is what you explained, that we have to exclude other diagnoses. And of course, this is easier in a younger patient than in a 60-year-old that has some vascular disease, and it would have been tricky to have this kind of diagnosis.
Yes.
I mean, this is a patient who otherwise is doing extremely well. She has, low count, genetically favorable disease. She's achieved a complete molecular remission promptly. She's a person that the patient we would think is going to continue to do really well. The two patients that I've seen, I'm afraid that's a very small experience. I don't think anybody can say they're expert in this condition. we gave both those patients steroids, but they were sort of already starting to improve, and it was very hard to say that the steroid. I mean, one would imagine in the sort of subcortical area there is inflammation, so there are reasons for using steroids, but I don't think anybody's ever. I don't think there's any data, particularly to support that. I suppose the other thing that just might be worth talking about is that sometimes it's a sort of clinically obvious gross syndrome like this, but it might be that there are far more subtle variants of this, and we do know that when we scan patients with ALL who've had quite a lot of intrathecal therapy and methotrexate, we do see an incidence of leukoencephalopathy longer term, and I don't think we have sort of data about long-term neurocognitive changes. So it's are you planning to scan your patient again further down the track, or?
Yeah, it's a good question. We decided not to have a follow-up on with the scan or the MRI. It was a decision that we made, so we don't follow. We just have clinical follow-up for these patients. Especially as you said, she has a high hyperdiploid ALL. She has a very good prognosis with this disease, so we have no specific follow-up with the MRI.
Yes, I mean, I don't think there's no clinical reason to do it, and indeed it would cause concern in the patient for you to continue to do scans, and if the patient appears to be functioning normally cognitively, then there isn't a clinical reason to do it. Are there I thought your presentation, by the way, was excellent, really, really focused, really, really good, and you've considered the problem from all the sides that need to be considered. It's really, really very good. I think it's a difficult thing to talk about because there's quite a lot of theories and not a whole lot of evidence. It's a fairly evidence-free zone, really, isn't it?
Yeah, I completely agree with that. It was a really nice presentation. We don't have any other question from the audience. So I don't know if you have some last comments, some Mark or Dr. Nicoletti, if something you want to add or to share.
No, I think we've really covered it, but I think it's really useful for the some of the younger people who are listening in to know about this syndrome, so that one day probably in their careers they will come across it, and if you sort of know that it's an established and well recognized syndrome, you know what to do. It's expected. An MRI scan absolutely should be done if possible. And you're right. One should always try and exclude other causes. But I think you've done that well.
Yeah, I agree with you. Just so people know that it exists and that they will think about it, because sometimes on the thing very important that you highlight it, that it can be up to 3 weeks after the methotrexate. So we must keep in mind that always still have 3 weeks after it can happen, and we can have this kind of pretty late neurological toxicity related to the drugs.
And also the fact that in the literature, when I was going through it, that there is an interesting review in Blood who say that the new treatments have neurotoxic aspects, like the blinatumomab and the CAR T-cell. So all these treatments are interfering. So we have to know which treatment could be responsible for them before deciding to stop or any of this stuff.
Yeah.
Yeah, and the thing is that sometimes also patients can have intrathecal methotrexate at the same time of the blina for some of them. So of course they can
Yeah.
this interaction, so it can be confusing.
Yeah.
So, yeah.
I suppose we also should just mention that as well as stroke, some common manifestations of this are, confusion is a common presentation. Obviously seizures can occur, but it's quite polymorphic. You can get a mixture of all those syndromes.
So any last comments?
No, I think we're good.
Okay, so thank you again, both of you. This was a very great presentation again on a very amazing discussions. And so it will be also make available after on the IATH platform, so we can watch it again, and you can also share with your colleagues on to bring awareness on these important topics. And we'll be happy to see again all of you for a new IATH Junior Club. So just keep posted regarding the update on the next journal club. So thank you and goodbye.
Okay, thanks very much. Well done.
Thanks.